Welcome to Virtual Face-to-Face with President Bruce Jarrell. I'm Alex Lakowski, Executive Director of Media Relations. Grow old with me, poet Robert Browning famously wrote, "The best is yet to be." Well, that can be true, of course, but it's by no means a guarantee. Browning lived to the age of 77, which for the 19th century was quite good. His wife, Elizabeth Barrett Browning, died at age 55. But the idea of ensuring healthy, vibrant, and meaningful lives well past what we think of as retirement age has never had so much support in popular culture as it does right now. Now, that I'm sure is largely due to the fact that as a population, we are getting older. Here in the US, between 2006 and 2016, the population aged 65 and older grew from 37 to 49 million, an increase of about a third in just a decade. And that's expected to nearly double again to 95 million by 2060. Maybe more surprising, the 85 and older population is projected to more than double from 6.4 million in 2016 to 14.6 million in 2040, just 19 years from now. Now, looking back, the average child born in 1900 would reach only his or her 47th birthday. But today, with improvements in the infant mortality rate, modern medicine, workplace safety, life expectancy is more than 78 years. And if you've made it to 65 today, it's even money, you'll make it to 85. But what about the quality of life you'll have? Every high school chemistry student knows about entropy. Things left to themselves tend to break down. Now, in humans, that means joints, hearing, eyesight, mental state, everything. Now, the good news is that we can influence that process with nutrition, exercise, learning new things, and staying engaged. Bill Burton, the man Governor Tawes once called the captain of the Chesapeake, was once asked his secret to longevity after a half a century as a newspaper columnist. He said, "If you have something to do tomorrow, you probably won't die today." Unfortunately, a recent ProPublica Urban Institute study shows more than half of workers who enter their 50s in stable employment are pushed out of those jobs before they plan to retire. The damage can be both financial and emotional, leading to a slew of unanticipated health issues as well as the loss of important social contact. The quality and availability of basic services like healthcare are also critical quality of life components, and that's where Maryland shines. USA Today rated Maryland the second best state for older Americans, saying it ranks as one of the best in the education, income, and health components. And US News agreed with that, ranking the Old Line State number 6 in healthcare. Maryland is also at the front of the pack with other services like advocacy for elder rights, community wellness and nutrition, financial education and fraud protection, and support for aging in place, which is very popular right now. The newest trend, and one UMB is proud to be a part of, is the development of age-friendly universities. In 2012, Dublin City University developed the 10 principles of an age-friendly university, highlighting the unique role that institutions like ours can play in responding to an aging demographic across societies and around the world. Today, there are more than 75 universities, including UMB, with the AFU designation. And as our geriatrics and gerontology website will tell you, here at UMB, we see aging not as a problem to be solved, but as an opportunity to change, to serve as a catalyst for innovation and change. Joining Dr. Jarrell today to talk about this are four distinguished guests. Rona Kramer is Maryland Secretary of Aging. Dr. Nicole Brandt is the Executive Director of the Peter Lamy Center on Drug Therapy and Aging at the School of Pharmacy. Dr. Jay Magaziner is Professor of Epidemiology and Biostatistics under a joint appointment with the University of Maryland College Park, and is Professor and Chair of the Department of Epidemiology and Public Health here at the School of Medicine. And Dr. Diane Martin is the Director of the Geriatrics and Gerontology Education and Research Program, known by most of us as GGEAR, and Associate Professor at the Graduate School. Welcome to you all. Now, let me quickly tell the audience this program is being recorded, of course, and we will be posting it on the UMB homepage, umaryland.edu. Later in the program, you will have a chance to ask questions. Please look for the chat button, select Chat with Host, write your question there, and don't wait. Do it now if you have a question already. When the time comes, we'll call on you by name, so listen for that. I'll unmute your mic for you, so all you have to do is speak up. Now, with that out of the way, here's your host, UMB President, Dr. Bruce Jarrell.
Thank you, Alex, and it's a pleasure to be here. I'd like to welcome those of you in the audience. Thank you for attending. I think we've got a pretty interesting topic for today, and I'm looking forward to the discussion. I'd like to start with questions for Secretary Kramer. Of course, Madam Secretary, we've heard so much about nursing homes and extended care and the elderly population in Maryland with this COVID epidemic. There must be other challenges that are facing the state of Maryland relative to aging and our increasing population of older adults. What's on your agenda of the highest challenges and therefore priorities?
And the extreme population growth in our demographic is something that we didn't tackle early enough, I believe, in the United States. We knew it was happening. It wasn't going to be a surprise to anyone. And yet the aging programming did not change to deal with it. So you discussed, or Alex certainly discussed with us, the population changes and growth. Right now in Maryland today, there are more older adults, people at the age of 60 and over, than there are all of the children in the school system. People don't think of it that way, and that difference is growing every year. So we need to change our thinking. We need to continue providing the services that we already do. Most of our services at the Department of Aging serve people who are either Medicaid eligible or within a close window of becoming Medicaid eligible. And we provide many services that do help those people to stay at home longer. That is the key. How do we keep and allow people to live at home as long as possible? But we're missing a huge demographic if we are not doing some prevention to prevent people from becoming Medicaid eligible.
So UMB, of course, has had a long commitment to aging and aging research. What are the ways that we can interact with the Department of Aging to make your job more effective and obviously to add our expertise to the discussion?
We've got to innovate. All of us have to innovate, and UMB can be a wonderful partner, and really already has been, in that process of innovating. And we've got to do more of it. And we could develop more partnerships to, number one, create innovation. Having a tremendous challenge is a tremendous opportunity. And it's an exciting time to innovate. And then, of course, along with innovation goes the evaluation that's necessary. So at the Department of Aging, we developed 6 years ago, we began a program called Maryland's Community for Life program. And the goal was to start keeping older adults who are not Medicaid eligible, but middle income, living at home to prevent spend down. Because a fall, a medication error, a fraud, a financial fraud will start the process of spend down. And within 2 years of living in assisted living, the average individual becomes Medicaid eligible. They've spent down. And so we believe at the Maryland Department of Aging, if we move our services up the timeline, just as our healthcare system already has, they've worked their way into prevention in Maryland. Maryland has a waiver with CMS that requires that we spend less money by creating prevention of health problems. We need to do the same thing with our aging process. And our Community for Life program is sustainable because it's a partnership between nonprofits who are very well seasoned in providing services to older adults, and they include a membership fee that is a cost a fraction of what actual provision of those services would cost for a participant. So these are people that we've created a program that is financially sustainable without becoming a burden to government, and yet we know will keep people living at home much longer, prevent spend down, prevent Medicaid support.
Thank you. It's a great way to think about it, and one that I hadn't thought of before, to prevent people becoming Medicaid eligible. I didn't think in those terms. I thought in terms of, well, you want people to stay healthy, but that really is a nice way to think about it, I think, and a good way to drive your program so that you're getting people early in this process. That's the key. And of course, throughout the state, we're learning that in all of our healthcare, aren't we? Not just about aging, but about everything that we do in healthcare. Well, one other question before we get to our other panelists. There are significant federal dollars. What kind of state programs do you have where you're spending significant dollars? Tell us how you're creating these programs that you just mentioned. Where's the funding for them coming from?
From the state. Maryland is this Community for Life program is strictly a Maryland innovation, and no other state is doing anything like it. And I think when I said we're behind the 8 ball, we really are. This is something that should be a national program, but the money coming for that program is seed money coming from the state, because the feds are not doing that type of innovating.
That's phenomenal. So I guess we've got our state government and the governor to thank for all of that.
Absolutely. Governor's been very, very supportive of these innovations.
That's really good news. I do want to give our panelists time to comment before we have questions. We have a lot of people out in the audience, so I'm sure there will be questions. A number of years ago, I sat with Freeman Hrabowski in our Glad Hill boardroom, and I learned about age-friendly universities, and I learned that we were going to become one of them, and so we have become one of them. Tell us what that actually means to be an age-friendly university, and how do we get better at this? Because I don't know that it's widely recognized that that's something that UMB is. Who'd like to address that? Dr. Magaziner, Dr. Brandt, Dr. Martin, who wants to go first? Jay, you're muted.
Yeah, I think Nikki, who's been one of our leaders in spearheading the effort to become an age-friendly university, probably is the best person to talk about it. And then I could talk about some of the research we're doing, and Diane will talk some about the outreach and education related programs that she's leading.
Nikki?
Yes, well, thank you, Dr. Jarrell, and thank you, Secretary Kramer, for your comments and programs about innovation and sustainability. So as mentioned, in 2019, we launched the Age-Friendly University, really with the vision to build on existing programs that have been at the University of Maryland, Baltimore for quite a long period of time, predating my existence there at the Lamy Center. But the intent for this is really for us to be more intentional and systematic in our approach to aging through our research, through our educational initiatives, through our engagement with our communities, and really all teach, all learn, with having our community members be a part of our educational training has been so groundbreaking in terms of the advancement of our learning too, of the community needs, just like you talked about the Community for Life. And so it really built on existing work that we're doing. So each of us are going to showcase some of that work, President Jarrell, and I'm going to turn it back to Dr. Magaziner to talk about that, and then we'll talk a little bit more, and I'll close off that segment.
Okay. Bruce, am I on?
Yes, you're on, Jay. It's your chance. Go.
Thank you. Thank you. So what I'm going to do is talk for just a few minutes about some of the research that we're doing at the university. And I'm not going to talk about specific studies. Instead, I'm going to talk about the number and the breadth of the programs that we're doing work in. And I think if you look at the basic principles of the age-friendly university, it really speaks to the university's research agenda as it is informed by the needs of the aging society, and it also is encouraging participation of older people in our research. So the among the things that we have been doing, we have a lot of our programs come under a big umbrella that we refer to as the Center for Research on Aging. It's a campus-wide program that includes faculty from all of the schools on our campus, and as well as at the University of Maryland, Baltimore County campus. There are a few members from the College Park campus, and we're actually having more ties with the College Park campus in our center, and also the National Institute on Aging, which is located here in Baltimore. So it's very much science-based. And we also, so let me show you, it's really a center without walls. And the goal is really facilitating research. Thank you, Alex, for putting that slide up. This is a diagram that simply lists the many programs that we are engaged in on the campus, and these are only the ones that I'm aware of. And as you can see, the Center on Aging is in the center of these circles, and it exists in a context of many other pieces, both inside the university and out. So we really don't want to be isolated. We want to be integrated. And we have, I think, we have a Pepper Center, which is a clinical research center. We have a Peter Lammy Center on Drug Therapy and Aging, which Nikki leads, and I think the name of it speaks to what it is. We have a Baltimore Hip Studies led by one of our faculty, Denise Orwig, and this program is probably the largest program on hip fracture recovery in the world. We have a geriatrics and gerontology education and research clinical research program, and that's the program that Diane leads, which she'll talk about. We have a program in the VA. There's a program at UMBC. I won't go through all of these. I think would preclude a lot of questions. We have a program in the School of Nursing, the Center for Biology and Behavior Across the Lifespan. There's a program on law and healthcare in the School of Law. The Center for Advanced Chronic Pain cuts across multiple schools, including nursing, dentistry, and medicine. And then there's a program on patient engagement with the School of Pharmacy. And the Erickson School for Aging Studies is on the Baltimore County campus. So there are really multiple programs that come together and really are trying to find new solutions for dealing with the problems that are faced by older people, both in the laboratory, some of these are very basic science oriented, the clinic, and then in the community. So we're really working across a spectrum. There are also training programs where we teach students to do research in aging, and they draw on a lot of the research programs. I want to leave you with one piece of information, which we might come back to, is the need to do two things: involve more older people in our research and persuade researchers at the university to include more people in their research. And I'll give you one example of where we've really, as a country, as a society, fallen short. We do a lot of drug studies. We study the benefits of medications, and these medications are used largely, not solely, but largely in older people. Older people are taking a lot of drugs, but these drugs are tested primarily in healthy younger people. Yet when they're used in older people, we follow them, we see what the side effects are, and that's where Nikki's program comes into play to say, well, how can we sort all this out? Because we're not necessarily doing the right thing by use of these drugs in the way we are. And we need to open the door for more inclusion of older people in this research. The NIH has pushed it. Our CTSA program is starting to think more about this. So that's a very big piece of how this age-friendly research environment will play in this new era of age-friendly.
Thank you, Dr. Magaziner. I know we had a lot of difficulty getting older age groups in our vaccine trials for COVID as well, and yet it's a critical participant in the trial. Dr. Brandt?
Sure. And to build on that, I want to actually let Dr. Martin talk a little bit more about the educational aspect. So Dr. Martin, and then I'll follow up after her.
Dr. Brandt. So as my work as the director for the Geriatrics and Gerontology Education and Research Program, I do work closely with Dr. Magaziner to really encourage and support student and faculty research, to encourage people to even consider this line of research and the funding, help them to find funding for their various research projects, introduce new student researchers and faculty researchers into aging with an aging focus. So that's part of what we do in GGEAR. And the other part is really the education components. And that's what I've been really involved in the last couple of years, both at the community level as well as on campus and across all the University System of Maryland institutions. So within the community, we partner with the Maryland Area Health Education Centers across the states. We've got AHEC West, Eastern Shore, and then the new Central Maryland AHEC. And the purpose of these types of programs is to age educate the professionals who are already working with older adults. A lot of people enter into the field by default. They think I want to be a social worker and work with children, but then when they graduate and start looking for their first job, they see the jobs are working with older adults and they don't necessarily have that age education to support their work. And so we do offer a lot of professional education conferences to support those frontline workers, those professional workers, the geriatric professionals, to provide them with the education they need to more effectively do their jobs and promote quality of life for their residents, for their patients, et cetera. Another component within the community is I collaborate with a lot of state and local agencies that are serving older adults on their task forces and their educational planning committees. Right now, I'm working with the Department of Aging, the Maryland Department of Aging, on a project called the Maryland Dementia Capable Community Connections Program. And this initiative, which is funded federally, is we're collaborating with partners across the state, the Johns Hopkins Geriatric Workforce Enhancement Program, the Living Well Center, the Alzheimer's Association of Central Maryland. And we're developing and delivering a statewide series of workshops for frontline agency staff to be dementia informed in order to respond to the needs of their clients. Again, in order to support aging in place, we need to have the educated workforce for the services, for the programs that these families and older adults themselves are going to be tapping into. And so we need to provide the education, whether it's age education or dementia education, so that they're better informed and can better serve the needs of the clients that are reaching out to them. So that's just a hint of some of the community work that we do. But as far as the educational components for our own students, again, we work in partnership with the Maryland Area Health Education Centers for a program that's called the Geriatric Assessment Interdisciplinary Team Program that's now in its 28th year. And this brings students, health professional, and social service professional students from all USM institutions together for this team building, in which they go out to sites in medically underserved communities and work with clients in groups of 4 to 6 students from diverse educational backgrounds to learn how to collaborate together and when to reach out to other professionals who are going to be the experts in whatever that field may be. So you have, your social work, who's the expert with the resources, but then you have the audiologist, the nurse, the physician, the physical therapist or the occupational therapist. They each have their own level of expertise. And so these activities help students to see the expertise that other disciplines can bring to the table to work most effectively with older clients. And in my talks with the state, we've actually identified a needed education. We've got, our PhD program in gerontology. There are master's programs in gerontology, but there aren't any programs for those frontline workers, for those health workers who are working in long-term care or in community care to provide, to earn their own age education. And so we just launched our new age-friendly specialist certificate of achievement program, which is a non-academic educational program designed to broaden understanding of the processes of aging and to enhance skills important to interactions working with older adults. And that came specifically out of talks that I've had at the state level for where is that needed education. So that's the type of collaboration that we're able to do.
Thank you, Dr. Martin. Sounds interesting. We all need that certificate, I'm sure. Dr. Brandt.
Sure. Thanks, Dr. Jarrell. As you can see, the passion and the energy and the history of the great work we've been doing on the campus. I do want to share, as we launched the Age-Friendly University designation, we also engaged the University of Maryland Medical Center as part of an age-friendly health system movement. And for those of you not familiar with the age-friendly health system movement, it really focuses on what matters to older adults and those who care for them. It builds on the 4 M's. What matters? Medication, which you've heard a lot about already. Mentation, which looks at depression and mood, delirium and dementia, as well as mobility. And we know, and we've learned a lot during this pandemic, that being able to access services and get out of your home is really important to get some of those resources. So mobility is not just fall prevention, but really the importance of transportation in inner city as well as in our rural communities. And so the University of Maryland just joined the latest action community, which is part of a huge national social movement with the Institute for Healthcare Improvement, as well as the John A. Hartford Foundation. And you may remember, President Jarrell, that we had one of the members from the Hartford Foundation present when we launched the AFU. So really excited about that work. And what's also exciting about that is it parallels and supports our work that we're doing as part of a geriatric workforce enhancement program. Throughout the United States, there are 48 centers federally funded by HRSA, which is the Health Resources and Service Administration. And again, Maryland has had a strong partnership, the University of Maryland, Baltimore, with Hopkins, as well as now MedStar, to align our health systems to work more with programs in our community. And through that partnership, we've been able to sustain a program, as we've heard the theme, Aging in Place. Well, the course actually is called Aging in Place. And we're working with our West Baltimore communities. And we've been able to evolve that program, not just to expand it in our West Baltimore communities because of the importance of partnership with organizations like the Enterprise housing sites, but also our own community engagement center. And we really want to thank that work has now spread internationally. And we're working with colleagues at the University of Helsinki and students from both Finland and France this semester because of platforms like this, where we can exchange ideas. But the principles that are needed is so important today because we need to expand beyond our classrooms to our communities. And here in the state of Maryland, our faculty, our staff, our students have been working with some of our age-friendly communities and counties, such as Montgomery County and Baltimore County. And I really am excited to learn more from each other about what initiatives can we expand and strengthen, and look forward to the questions from our community members.
So I can always tell when Alex has got a lot of questions, and so Alex is squirming in his chair.
I'm not playing poker with him. I'll tell you what, he can read me like a book.
But thank you, Dr. Brandt. That was very interesting. And so I think I'm going to let Alex. Okay, Alex, it's time.
Well, it's not about me. It's about the questions. You know, you can't talk about aging really without talking about children, even grandchildren. I want to bring Becky Sorrell in here because she's got, well, it's really the question or the issue of the day. Becky, do you want to explain what your question is?
Hi, good afternoon, everybody. So on Saturday Night Live recently, there was a skit called Baby Boomers Got Vaxxed. I don't know if anybody on the panel has seen it, but maybe you'll go look at it now. But basically it was all the baby boomers taunting us, all younger people, about how they've got the vaccine and how they're free to do whatever. So what suggestions do you all have for those of us with baby boomer parents on how to talk with them about the importance of continuing to follow COVID guidelines after they get the vaccine?
Becky, we should warn people. You told me that skit is not appropriate.
Not for work,
Not for work.
for work.
Okay, so just be careful if you go and find that.
Secretary Kramer, you have any wisdom on that one?
Actually, our older adult population is the population that's been the most enthusiastic about getting vaccinated and really have been the most compliant. Now, there's a whole lot of pent-up energy because they're also the group that stayed in through the pandemic. Really, we just continue to ask everyone to be cautious. But I have to say that our population of older adults have been and continue to be the most compliant. They do want to hug their grandchildren, and that's okay.
Yes, I agree with that's okay. Any other comments? Dr. Brand?
Sure. Yeah, Becky, that's a really important point because they may be vaccinated, but not everyone around them is vaccinated. I just saw a patient yesterday. They got together for Easter and so excited to get back together, but not everybody is vaccinated. So, there's still that potential of others carrying the virus. And even though they've got the vaccine, they still could get infections. And we've seen some recent outbreaks in nursing homes, even though there's been vaccination. So I just to be mindful that we're not over this yet, but we need to be safe, and especially for our older adults in the community.
All right, Vincent Conroy wants to pick up on your point about mobility and how important that is. Vincent, are you there?
I think so. Yep.
Yes, you are. I can hear you. Go ahead.
Appreciate that. And thanks to the panel for a wonderful conversation about stuff that is really needed for the older population. And the older adults. I just wanted to know, and this is, I don't know, I guess for everybody on the panel, is there any legislative traction for considering prevention funding strategies to be covered for the individuals to keep them mobile, such as, like tax deductions for gym memberships, insurance coverages for preventative exercise, that sort of element. That prevention word seems to be something that tends to cut resources off for folks when it comes up in any type of documentation. I'm curious to hear your thoughts.
Who wants to take on that one? Sounds like policy, Secretary.
It is. As part of Maryland's global health program, we are now paying for, and Medicare pays for, some prevention. And though it hasn't gotten entirely to gym memberships yet for the entire population, that's the place I think it's going to have to go. I don't see any future for tax deductions getting through the legislature. Those are really hard to pass, but certainly as we focus more as a state, and we're innovating more than most other states, as we focus on prevention, more and more of those services, the staying healthy opportunities, will come along as part of our programs. But right now, it is encouraged more and more by the medical community, but it still is pretty much that, just encouragement.
Anybody want to add anything? Dr. Brand?
Sure, Dr. Conroy, that's a really important point. And, I know of your great work as a physical therapist and working in the community. And I think to Secretary Kramer's point, to think about payers and insurers paying for gym memberships. I know other states who have more Medicare Advantage plans, maybe than we do here in Maryland, do pick up some of those programs to pay for gym memberships. But I think a lot of ownership needs to be on our health systems to do more screenings. And I know we're trying to do that with our annual wellness checkups that are offered by Medicare. And then hopefully we can get back to our stepping on programs that we've been doing in the community with our community partners. So those are additional ways, but love to hear your thoughts if you have additional angles, especially from your vantage point.
Could I add that all of our area agencies on aging throughout the state do have classes for physical training, and the senior centers across the state all have some type of activities. Many of them have wonderful gyms.
Okay, Alex.
All right, Tim Santoni has a question about the challenges that we face regarding behavioral health. Tim, are you there?
Yes, I am.
Go ahead.
I happen to be president of the board of the Mental Health Association of Maryland, where we have an advocacy group for older adults behavioral health. We work very closely with the state, and I'm happy to say that the state has really, Stephanie O'Day, who works for the state, has really stepped up and gotten a coalition of older adult stakeholders from the state and from external stakeholders as well together. Behavioral health from older adults is a real challenge because Medicare coverage for behavioral health is absolutely terrible. They only pay for a physician or a physician extender. The rates are relatively low. The co-payments used to be 50%. The only good recent news is that they've now made those back to 20%, which is what the other services are. But there's really a lot left to be desired in terms of the Medicare coverage, and it's worse for people who have money because if you're dually eligible, you can access public behavioral health services. But if you're not dually eligible, you're going to have heavy copays, and you're not going to have access to some more intensive services that you might need.
Any comments related to those interesting points?
No, I agree.
Well, he said it. What do you mean? Why wouldn't he be allowed?
Why wouldn't it be allowed? Well, insurance companies won't pay for most of those services. Generally, insurance companies pay for inpatient services, partial hospitalization programs, and outpatient services. Anything in between, case management services, psychiatric rehab program services, are not services that would be covered.
I'll just add a commentary. I couldn't agree with you more. I think especially now we need to look at our behavioral health programs, and advocacy is key. I know just recently I advocated for the protected medication classes, which disproportionately affect those with mental illness because they were talking about changing formularies once again. So it's access to programs, it's access to medications, and I think, there's more advocacy and work that needs to be done here. And I know the center I work with, we've been focusing on some of the safety perspectives of these medications themselves, and we know, especially in older adults, we need that cognitive behavioral therapy. We need that, and I think now more than ever with social isolation of our older adults being disproportionately affected, you're right, more work needs to be done to advocate for these services. And more training, I'll be honest. I think there's also a shortage of individuals who are trained to care for older adults with different mental illnesses.
Great, thank you. Alex, let's move on.
All right. We've talked about this group, a certain group, but about them. We haven't really used the term. I'm going to bring in Patricia Fanning, though, because she raised the term. You want to say what it is and what your question is, Patricia?
Yes, baby boomers. Can you hear me?
Yes, absolutely.
Excellent.
Baby boomers.
Well, so I'm speaking as a baby boomer, and I want to point out that my slice of the demographic has a habit going all the way back to the 60s of advocating for or against or protesting for or against various things. And so the question I have is, what should we be advocating for now, either for our own group or our elders, because there are people who are, still quite older than we are, or those just coming along right behind us, rather than just like joining AARP and leaving it up to its lobbyists? What should we be doing right now to make it better for those different groups that come after and before us?
Anybody?
Well, I think one thing, I mean, I don't have a concrete answer for you, but I think we have to ask the question of ourselves, and I think I fall into the same category you fall into, and many of us do. In fact, that's partially related to the big explosion that Alex was talking about, what some people call the aging tsunami. But I don't want to be in that nursing home. I want to be at home. Now, the question is, what can we do to innovate and find ways of doing it in a way that's affordable? Can we deliver better long-term care in the community outside the institution? And I think there's more and more interest in doing that. And I think there's a recognition that that's what older people want. But I think we need to ask the older people themselves, what is it that you think would help you, and work in that direction, rather than, saying what, we need to include that older person in the discovery. That doesn't answer your question, but it might provide a strategy for getting an answer.
That reminds me of the patients program that sits in the School of Pharmacy,
Exactly.
where they involve the community in designing research questions. And maybe we need to have the same kind of philosophy relative to aging.
Well, actually, you're absolutely right, Bruce. And in fact, the Center on Aging has partnered with the patients program, in that we are looking at how do we involve more older people in research. We're specifically working with community groups to do that. And, we do it to the extent that we have the resources to do it. If we had more, we could do more.
Any other comments, Dr. Brandt?
Sure, I always have a comment, but I want to make sure Dr. Martin, if she has any, or Secretary Kramer, before I go.
I think Secretary Kramer had her hand up there.
Well, thank you. Certainly, there are many, many opportunities to advocate for funding for new programs. And maybe there needs to be a central resource. So those of you in the community who would like to help advocate would have that. But there are certainly, as Dr. Magaziner noted, lots of things we need to be for which we need to be advocating, and maybe we need a more centralized source. There used to be an organization in Maryland that is not particularly active right now for advocating for programs for older adults, but there are many opportunities. If you watch even the state legislative session, where your advocacy could be very much helpful and appreciated.
I would put my hat in that we need to advocate for an age-educated workforce. In the industry, there is an extremely high turnover rate. The training that's provided for home health, for frontline workers in care communities is extremely limited. And the turnover rate right now is close to 60% in these industries. It's very costly to the long-term care communities, to the home health agencies. And the number one thing I hear when I'm out talking with people about why they leave, what's written in the literature, a lot of people think it's because of the lack of pay, the low pay amounts, but it's lack of understanding of what the job actually entails. And we also know that when we can provide the knowledge and skills, that we support that workforce, and they're more likely to stay in the workplace. So when I think of a baby boomer, I think in the 1970s, how they advocated for educated teachers. You didn't necessarily need to have, much more than a associate's degree or a bachelor's degree in some cases to be a teacher. And now down to the preschool level, you have to have your college degree in early childhood education. I would love to see the same type of thing if you're going into aging, that, a lot of people fall into it because that's where the jobs are, but they're not prepared for what they're actually working with. And so I think we need you baby boomers to be out there and advocating for an age-educated workforce, regardless of whether it's in long-term care, community health, at the government levels, we need people who are knowledgeable about the aging processes.
Okay, Alex.
All right,
Cleveland.
everyone on campus knows yesterday was IPE Day, where we teach interprofessional education, team-based care. So I'm so glad Cynthia Boyle has this question. Cynthia, go ahead.
Hello, everyone. Thank you. UMB does a really good job of introducing students to interprofessional education. We've continued virtually and do many modules and all that. So my question to all of you is, how can we better link our efforts in both interprofessional education and practice with aging initiatives so that all our health profession students are proficient and committed to the care of older individuals?
Great question, Cynthia. Who wants to take that one on? Dr. Brandt.
Oh, yeah, I'll start with that. Thank you, Dr. Boyle, for that question. I think we need to ensure, at least at UMB, time for students to do interprofessional and then partner that. I know we've been working with the schools of nursing, schools of social work to some extent, schools of medicine at time, as well as schools of pharmacy, of course, to partner with our communities to do annual wellness visits. And we have found through our work with primary care, to some period of time, those weren't being done consistently for people who were eligible. So we're trying to teach those principles early on, which taught us great communication principles, working together, which also helped us to reach the needs of our older adults in the community. And one of the things is just partnering with community members to work with us. So to that last person who asked a question, please volunteer through the schools. We have a website we'll share with you, and feel free to reach out to any of us, because you're some of our best educators is working with our students. So I think my vision and hope is that we'd have protected time. We'd have accreditation standards that really instill the principles of gerontology and geriatrics across all the curriculums throughout our health training programs. And that's why I've been working closely with HRSA on our geriatric workforce programs. So, so those are just some of my thoughts, because these relationships we start now with our communities, with our professionals, go beyond their time here at UMB. And we've seen that in terms of our investment. So thank you for that opportunity and great question.
Pharmacy has led the way when it comes to IPE and inserting it into their accreditation standards.
Mm-hmm.
You were way ahead of most of the other schools. Do you have aging education standards in your credentials? Do you have any idea whether that's included?
Within the age-friendly university credentials, Dr. Jarrell, or?
Within the School of Pharmacy accreditation?
We do have some aspects of those, yes. And within the School of Pharmacy, we did put together a particular training program in geriatrics and palliative care, because a lot of those principles really support each other with advanced illness.
Any other comments by our panelists?
I would like to see more of that in other schools, of course. But in addition, we need to see more in the health system, the medical system, which is not just doctors, it's a whole array of professionals. And I'm hoping that the age-friendly health system can start investing. And it's not very, you don't get a lot of money back when you treat an older person for the many problems that older people encounter. And we can get into the economics, and I think we have to get into the economics of that investment. In the long run, has the potential to keep people out of the hospital and keep people from coming back to the hospital after they have costly procedures. But we haven't shifted the responsibility in that direction as I believe we need to.
And Jay, to that point, I just want to jump in for a second. There has been some really well-established business calculators about the age-friendly health system work. And really the greatest, even more impactful value is when we partner with the community, just like Secretary Kramer talked about the Community for Life programs, because, it goes beyond our institutional settings to partnering with our community settings and looking at the global cost of care, right? Not just one budget.
We've done some grant programming that has proven that when the Department of Aging, and we don't provide medical services, we do the supports in the community. And when we get involved on hospital discharge and find the supports in the community for the discharged patient, that we definitely can decrease the readmissions. And we call it our hospital to home program. So there are supports in the community. The problem is finding them. And when we create that linkage between the hospitals and the community, we can reduce the costs.
Thank you. Alex?
All right, we still have lots of questions. Let's go to Casey Knopp. Casey, go ahead.
Hi, actually, Kismet, great opportunity. Secretary Kramer, I was actually the GRA working with MDOA on the No Wrong Door grant the last 2 years. And I have to say, I really hope there are more opportunities to work with you guys in the future, because like you said, it just makes a huge difference. And it was a lovely learning opportunity. And my question is kind of based on my experience with that. So I'm really curious as to whether or not COVID-19 has kind of shifted policy focus within Maryland as it pertains to kind of those aging populations, if there's a large focus on state plan, because this kind of is this new way that we're going to have to approach things like keeping people in the community, providing those sorts of services, and if any specific problems or concerns have kind of been brought to the forefront by the pandemic.
It's certainly, the pandemic has absolutely put the population that we serve at the forefront. No question, but that every single state department is now looking at what's happening in the aging, the Department of Aging and our programs. It has shined a bright light on it, and I do believe that that will help us in the future. So definitely see it. I think that now that the world is looking at aging the way we were trying to look at it a number of years ago, and living at home longer, if not for the rest of one's life being the standard, not the exception, the pandemic has made that the focus where it was not before.
Other comments on that? Okay, Alex, keep them coming.
We've heard from a number of professors. Here's a student, Kola Bakre. Kola, are you there? Oh, I'm going to give you one more chance. Well, his question is your working relationship, he has actually a two-part question. Is your working relationship with the Erickson School of Aging Studies at UMBC just for the purpose of research, or are there other working relationships that you've established? And what's the prospect of employment for people who undertake this course of study? So he may be interested, I think.
If that's for me, I would be happy to answer. We have from time to time looked for advice from the folks at the Erickson School. We bounce ideas off. We have taken advantage of that. Research tends to be the major focus because we've got the clients, we've got the people who could become part of a research study, but we need assistance in innovating, and university is the best place to go for that. And we also, of course, need evaluation, which we don't have the capacity to do at the Department of Aging. And I would like to say that we are always looking for great new staff people at the Department of Aging. I can tell you that an Erickson graduate came to us at a low-level position a number of years ago, and within about 5 years had become the chief of staff. at the Department of Aging. So there is great opportunity, and would highly encourage graduates and students to apply to us.
Yeah, and I think in a general sense, I can't speak to the Erickson School, except we do have regular conversations about things we might do together, and their policy directions we featured in a recent symposium on Alzheimer's disease that we did an interdisciplinary symposium, and the Erickson School was very important for that. The future, though, for people who do work in aging, whether it's from the Erickson School or elsewhere, I think if you look at the aging of the population, that's sort of a no-brainer. There has to be a place for employment. It's really, as Diane points out, we need to make sure the workforce is educated, and we need to really promote the different opportunities that can be created in innovative ways.
Hey, Jay, you have a gerontology program.
Yes.
Do they have any trouble finding positions once they graduate?
Absolutely not. They find positions at universities. They find positions within government, working at CMS, working at the different foundations. I mean, they're really AARP. We have people working, as well as direct service. So no, these graduates have no problem finding work.
And there's also a residency, or there used to be a residency through the Andy Goldberg's program.
There's a special fellowship. There is a fellowship program in aging. It's mostly clinical, but we do offer opportunities to continue. And in fact, our training program has now started to open a path through surgery, because our surgical residents, to the advantage of the way the surgery department is operating, Bruce, which you probably know this well, has a 2-year period for doing research. And we now have a path for some of the surgeons who are interested in aging to come into our program. And that's a very high priority.
And to expand on that, President Jarrell, we've had a residency in geriatrics for 20 years, and our students have gone from industry to government. We've now launched a fellowship, and our first graduate just went into healthcare system management. And we have our graduate student program, and there's no shortage of them finding jobs at the FDA or other agencies like CMS with their research background. So to speak to the point, there's a lot of opportunities, not just locally, but nationally for students with gerontology and geriatrics as training.
Well, that's certainly good news, I think, to hear that things are going well that way. Alex, we have time for one more question. Do you have one?
Oh, I've got more than one, but I think let's hear from Sue Lockenmeyer, who asks a question about something, an aspect of health is staying connected. Sue, do you want to explain your question?
Sure. Thank you. And hi to Secretary Kramer and all of you, Diane and Nikki. It's wonderful to see you and to be involved and hear what is going on there at the university. I think one of and Secretary Kramer mentioned the isolation piece. I just was hoping that the Secretary might talk a little bit about the innovative tablet program that the Maryland Department of Aging is initiating, and the work that's being done really to help folks who are isolated by connecting them to community-based services that are available and programs that are available virtually.
Absolutely. Hi, Sue. Great to hear from you. We certainly know, if we did not, and we did before the pandemic, that since the pandemic, we know that it is extremely isolating to be at home and not have the resources to interact virtually with the world. And we have many, many seniors who don't have those resources. They don't have the capability, the knowledge to use the internet appropriately, and many of them can't afford the hardware, the tablets and Wi-Fi, et cetera. So we've got a program that we are now implementing that will provide tablets to many older adults throughout the state. They will be all preloaded with Wi-Fi, and we are going to be incorporating medical and social well-being into the program. So we will be enhancing the ability of Marylanders to interact with their doctors through telehealth, with the Living Well Center and its Depression Pearls program, as well as being able to link to exercise classes and other virtual programs that will socially involve them. And so we are beginning that. We're really in the middle of the grant program. We'll be distributing those tablets soon. And that's funding that we received through the federal government for part of our CARES Act funding for COVID.
That's great news, Secretary. You've probably already thought of this, but having had a mother who was over 100 with a tablet, helplines and troubleshooting become very, very important. And so I hope your capability of dealing with that is good.
We expect that, yes. We
Yes.
will have training available and assistance available. That's really a major part of the
It is.
program.
It is. It is.
And I know my kids roll their eyes when I ask questions, so we knew to be prepared.
I can fix the car, but not the computer. So, well, listen, this has been a great hour. We should do it more. Secretary, you're invited to this campus anytime, and we hope to continue these conversations. You probably spend a lot more time here than I know. If you do, thank you. If you don't, you're welcome to do so. For Dr. Brandt and Dr. Martin and Dr. Magaziner, nice to see you here again. And hopefully we'll continue this conversation and become an even better age-friendly university. So thank you much. And those in the audience, again, thank you for your attention, as well as thank you for the good questions that you brought forward. Until the next one, thank you very much. See you later.
Thank you.
Thank you. It's been a pleasure.
Yes.